Hey Calvin, hey Reed.
Hello.
What's up, fellas?
Reed, I just realized that these meetings are at dinner time for you guys.
Oh, it wasn't a problem until now, actually, because the missus just got a new job and she's home. I would just cook dinner while we were meeting, feed the kids right after. Now that Sarah's home, she's like, "What do you mean you're qualified? What do you?" But no, it's
Hey,
all good. It's an important topic, and I like seeing you guys. We make it work.
hey
It's
Michael.
nothing like the COVID days when I was hosting a conference for Christina Higa at like 9:30 at night.
Oofda. Yeah, we all did some crazy stuff in COVID, huh?
I mean, it all depends on your perspective of COVID, but yeah, I mean, crazy, but yeah,
And THC had, I don't know what, like why, but like there were webinars. Like we literally had 4 or 5 different topic webinars every single day. I think it was just like they needed to have things for people to do, and like the default was, oh, let's host a webinar. So I ended up like doing a lot of like webinar kind of administration, like, like moving questions in and out of chat and doing a bunch of other that kind of stuff. And um it was crazy. We just had like, I think I had like a 12-hour webinar day one day. But it was way too much. But and then I got to see all the healthcare people, like just like, I don't know. I just, it was hard to watch people who are in the middle of everything, and you're kind of tangentially on the outside and just kind of get a front row seat to like kind of the mess.
yeah. No, it's hard not to stay up late answering the questions, right? Because you're like, damn, dude, you guys are going through it right now. Where are you?
Yeah.
On a lighter note, I'm excited to see you guys next month at Matrix.
Like month and change, right?
Yeah, probably.
Yeah. Yeah. Okay. Just it time is going by way too fast. I I want as much time between now and then as I can get. So
No, that's fair. Yeah, I know the feeling.
uh
Yeah, net inclusion snuck right up on me. But no, I just got off a planning call with my panel for Kathy's conference.
okay. What are you doing?
Digital equity with a guy from Christina Care, which is in Pennsylvania, and then director of EMS at George Washington.
Gotcha. All right. Well, I think we have kind of a group here. I'm going to be transparent and just say I've not kind of gotten through as much stuff on this as I was hoping to, and we're a little bit disorganized, but I thought we could at least check in. Last time we had met up, we had kind of taken some of the items from our framework and kind of split those off as research topics for kind of the group. I wanted to go through and just kind of see what people are finding, and if there's a particular things that we want to dive into at more depth, or if we need some more time to kind of go through and start to pick these things apart a little bit. But does that sound good?
Yes.
All right. See nods. See, hear yes. Okay. So I'll go ahead and just share my screen. That way you guys don't have to pull it up if you don't have the Google Doc in front of you. But we were looking at a few different topics. In the realm of patient-focused AI, we were going to look at a few of these items kind of came up, and this was on me. And then in the accessibility space, Reed was going to do a little bit of a dive into some of those. I can kind of walk through some of the things that I was able to find. Um, there's a lot of content on all of these topics, and basically what I've kind of gotten through so far is I'm just finding I want to find some examples of the technologies that are kind of in use, any white papers that kind of go through them, and then any any kind of literature reviews or studies. So I'm trying to pull these together. Most of the things I have in here, I have kind of glanced through at a high level, but I've not really done a close read, which is kind of the next step that I need to go ahead and do. But there is a lot of content out there on chat triage, the kind of the use cases for it, around appointment management, medication refills. I found a couple or companies that were actually doing it. This is a very small subset of. It seems to be a lot of companies that are kind of building business models around this, which I imagine is part of the concern, or is concern because of how accessible these tools are. Anybody can set up a chat bot to kind of make things go. This article here was on it was kind of just an opinion paper on chatbots in medicine. The main benefit for it was there was a lot of really good reference links to more scholarly articles. And I've not kind of gone down to that second level yet, but that's the plan for that. I don't know if you guys know Dr. Mesko. We had him kind of speak at a conference that we did a few weeks ago, and he's really good at a lot of the pop sci kind of conversational tech explainers things. So I've got an article in here from him, and we'll kind of go through those. He'll actually have some good examples of actual applications of the technology. There was a really good article on chatbots in public health. Again, I've grabbed it here, but I do need to do a dive into that to figure out kind of what levels that they're looking at there. What I thought was really interesting is they laid out some clear objectives, like what are the application domains, what are the different types, and what are the evaluation methodologies. I think that would be really worthwhile to kind of go in, see what they thought, see if there's anything we can kind of glean from that. And then I did find a couple things on, this one on large language models, and then the biases that are kind of built into those, particularly for, it was listed as chatbots, but it kind of boiled down to just using large language models in general for healthcare, which I think when I think chatbot, I'm thinking something a little bit more less just chat GPT, more kind of specific for healthcare. Looking at custom patient education, there was actually more out there than I had kind of realized. I kind of did a little bit of a dive, a couple example organizations that are doing it. There's a lot more research that I could be doing here around custom patient education. It looks like it kind of breaks into one of two camps. One is kind of using your patient education library and then kind of going through and picking out items from your patient education library based on kind of a profile that you're setting for your customer or for your patient. The other is actually doing summaries of information from the patient's medical record and doing kind of ad hoc EHR summaries so that you can kind of generate EHR records that are customized to the patient depending on kind of what the things they're asking you. So there's a lot more that I need to kind of dive in on there. And then medication management is the other one that we had listed here. There are again, I just kind of glanced off the surface here, but there's a lot that I'm going to be diving into on kind of some of the medication management. A lot of good articles. I think I heard this guy from Emory Health talk about what they're doing in here in this HIMSS article, what they're doing for AI improvement in their pharmacy. So we'll go into that, but there's lots. Again, I have not given this the attention that it needs, but I'm finding a lot of things that we can kind of start pulling together as resources. A lot of reading I need to do to kind of get up to speed so we can kind of draw some trend lines. Any questions on some of those? Okay. Um. We had listed these kind of in our overview last time, social determinants of health and resource generation. I'm not sure what I kind of want to do on those. I think maybe sticking with kind of the ones that we've been looking at so far. There's a lot of information on those. But I'll continue to dive into that, and I'd like to have kind of a summary of this category for us next time so that we can determine what in this space we want to kind of say. Reed, I had you down for looking at some of the things around accessibility. Have you gotten a chance to look at any of that stuff, kind of like built-in translation services or
Yeah, well, no, so primarily that. So I started to look into one, my bad, guys. I thought this meeting was tomorrow, and so I had this on my board, populating this on my morning calendar. But I'll get that in there so folks can look at it. But I did look at translation services a little bit. I need to do a little bit more there, I think. And then language complexity, I really kind of looked at it from a like communication perspective because I wasn't finding much in terms of like, real time considerations, right? Like, oh, that's, pretty scientifically phrased or whatever, but more so like, follow up messaging, medication adherence, things like that. But after that, I didn't fully realize that I was going to be in Philly for 4 days last week until last week. And so I have a lot more to do, but I'm hoping next time we get together, live translation and video, even some of the note capturing things, which isn't in this bullet in particular, but I've seen a lot of people in calls I've been on recently do it. So I started to dig into it, but like Zoom and Teams now have like not only closed captioning, but also like an AI based, summative document it can produce. And so that I think is something that I'm also hoping to tack on here. It might not be useful for this fact sheet, but it just felt like it was something that, fell into this bucket sort of naturally.
Yeah, it sounds good. And so to kind of repeat back, you found are you're finding kind of translation things like summaries of like live video and things like that. Oh, you're finding less around like, language complexity, like getting things down to a sixth grade level kind of things. Is that what you're saying?
Yes and no. In real time, I'm finding less language complexity stuff. There's a lot
Okay.
of things that will like analyze, similar to like Grammarly does for like a paper, and will help you do that and ensure proper verbiage transfer across languages. But and this is probably because I've been cursory, or maybe it's just because folks aren't too confident on it. But I haven't found much that's like in real time. I was going to say that sentence you just said, was spoken at a doctoral level, and I didn't necessarily like. I planned on digging in more because I kind of feel like there's got to be something like that out there. You know what I mean? Like Kari's got that project on inflection. I would imagine there's something that's based on grammar.
Okay. Sounds good. All right. Anything else to add on that one?
No, I think I'd be curious. There was a section where we talked about consent kind of in depth last time, right? And I'd be curious what if like to hear more about that because I have been finding nuggets of information, or at least though this study had to have considered it, haven't necessarily read those sections, but I can share some of those studies and stuff if that's still a relevant topic for this first endeavor.
I'm really I think we need to grab that stuff for sure. I'm not sure how we're still in the kind of the forming stage here, or I don't know what stage we're in. But I'm still confused, or not confused, but I still have a question. Like, are we consenting, like consent to the use of AI, or AI is performing consenting workflow? I think at least initially it's like consent to actually even use AI for healthcare purposes.
Right.
So
And that's what I've
I've had,
said.
yeah,
ahead,
I've
Brian.
had some great discussions with some people about this because I felt like this was really a very hot topic during our last meeting. It's pretty interesting the thought behind some of it because I think if we're talking about studies and technology that has not been pulled into the standard of care, there's consent. But as soon as it becomes part of the standard of care and the way that a health system does business, I think it's a different discussion at that point in time. Like we don't discuss consenting to come in and be on security cameras. We don't discuss consent to come in and have a CT done necessarily. Like it's part of the way that a system does business. I think that, where this is really going to come down to, I think if you're doing a study, there's a lot of consent, but if you pulled it into your main practice of care at that point in time, it's a little bit of a different discussion because you're not asking permission if it's part of what you're doing for all patients. And then it becomes an issue of litigation if something were to go awry, if it provided the wrong information. But I think that's a very interesting topic that's going to generate a lot of conversations around the lab that I'm working on for the Matrix specifically, because I do think a lot of people feel very passionate about AI and how it's being used. But what I think is what's going to come out pretty fast is that a lot of folks, like AI has become a buzzword in the last couple of years because of the chat engines and things that are out there. But the reality of it is it's been embedded into a lot of these services already, and we're starting to see it all over the place. So it's going to be an interesting conversation, and I think there will be a lot of ground to cover on consent. But it's fascinating as you start to have that conversation with anybody, in these spaces. But I think as we start to get into this is part of how we do business as health systems, it's going to be less about consent and, making sure that the system you have is providing the right information. Because if you don't, at that point in time, it leaves you out for lawsuits and everything. So fascinating topic. I can't wait to dig into that more.
Yeah, and Michael forwarded a really interesting article about liabilities using chatbot services, and it was kind of a low stakes. I mean, it was small claims court, $800 case, but
Air Canada,
Yeah.
I think looking at kind of what we're liable for if things don't, the AI gets something wrong, or B, if we're not using these tools and it's something that actually could help a patient, at what point do you become liable for not using the resources that you have, right? So if we have a tool that can kind of look at all of the best healthcare best practices and make a recommendation, and you don't use that tool because you don't trust it or you don't like it, I don't think that's a 5 to 10 year question. I think the 2 to 3 year question is what if it gets something wrong? But I really I think doing more in the consenting. We probably should reach out to Sylvia out of CTRC. I bet they have a lot of good insight into that. I know they were really probably around the consenting and the liability. I know that she's brought that up a few times. I got one more thought, and then I'll turn it over to you, Reed. I guess in responding to your comment, Brian, about we don't necessarily have to consent if it becomes kind of the standard of care, and that was always the argument we had for telemedicine in general. For the longest time, we didn't do any consenting within our tribal health organization because it was just part of, the care delivery. We weren't doing anything really different in delivering telemedicine, versus kind of anything else. And now the trend that we've seen has been that everybody is getting consenting for telehealth services. And so that it just seems kind of like there's been a sea change in the telehealth aspect of consenting. And I wonder if it's not something that would be kind of similar for AI. It seems like when in doubt, you consent, right?
Yeah.
Well, you're breaking up there, Brian.
Sorry. I don't know if it's going to get any better out here.
Well,
right.
we wait to see if his is any better. I don't
Go ahead, Reed.
know
Yeah.
if my comment, like, it is more into your comment, but it's a 5-year thing. Is it though? Because I mean, like, my rudimentary understanding of one of the court cases that it does exist for healthcare right now regarding licensure is basically that fundamental question, right? It is, was I acting within my moral and ethical duty as a provider because I chose not to provide care to this patient and they were in a different state and I didn't have that license. And like that's going to, I believe, one of the levels of the Supreme Court right now, and it's something that I remember one of the policy guys at one of our conferences 2 years ago saying that like he wouldn't want to have to be in the boat of saying, they chose not to honor the standard of care, the expectation that they have as a provider, because so and so said they were in a different state. And I was like, dude, don't say that on my stage. Like that's not how it works. And 18 months later, there's this court case in front of the Supreme Court. And then the reason why I thought of it is because I don't know enough about that case yet and what standards it sets. Is there a possibility that the language in that touches on AI, touches on technology, right? Like the language in whatever decision comes out of it says, you are within your regulations you adhere to first and moral and ethical practice considerations second, that would matter. If they say the other, that would matter too, right? Which is what the point you were making, I think, with AI. And so I just wanted to toss that out there. I do think this case matters a decent amount for telehealth. I don't know enough about it to say if it matters for AI.
Yeah.
But you
Well-
can see how that could, considering we're dealing with 1996 policy language as an hindrance to actual telehealth encounters. You can totally see how they accidentally rope AI into whatever decision is made.
So I'm not sure what legislation you're talking about. I probably should know, but yeah, if you don't mind kind of referencing that so that we can kind of article or
find it.
something. Yeah, it'd be great.
Yeah, it came up in the other sort of hot topic work group. Actually, Carrie from Michael's team was the one that had the case, statute
Okay.
ready. But I will find it and get it to all of us.
Yeah. See, just meeting up is worth the price of admission. I'm learning about all kinds of things. Hey, Calvin, you want to run through some of the items you had here from your provider support section?
Sure. So I did a search for AI assisted dictation, and that came up with a couple results. The first one that I found was Freed, which is kind of a AI dictation assist software, and then Augmendex. That was a really good resource. They had several white paper articles on AI and that sort of stuff. And then DAX is, of course, Dragon Dictation, the big player in the market space. They already have integration with Epic, and so that is a big. You have the top dictation software with the top EHR doing dictation. And then I found a couple other articles about EHR generative AI, and it actually went through kind of the top AI vendors and what I'm sorry, not AI vendors, but EHR vendors, and what they're doing with AI. So I thought that would be a really good resource to kind of just pull and have some some general information from. And then I also found another article there from Salute Labs about AI and EHR, kind of what we were talking about the records AI assistants. So I thought that that was really interesting. I didn't know if that really 100% fell under my categories, but I thought that that was a good resource.
So it like pulls together summaries and things like that from the record, like
Yeah,
custom summaries.
yeah, stuff like that, like how AI is actually going to actually improve. And these are just resources that I found really quick, and I haven't done a full deep dive on them all.
Yeah. I think we're maybe most of us are in a similar boat and we need to do a deeper dive. One of the things that you're kind of mentioning, and I'm really curious, is, and I've been thinking about this a lot for just telehealth and telehealth technologies in general. How much of this do we expect to be, especially the provider support stuff? How much do we expect this to be somewhat standalone, and how much do we expect it to be EHR embedded? And I would imagine for majority of this that like you're getting the AI enhancements that come with your electronic health record. Like to me, and even for like smaller or medium-sized organizations, that seems to me to be the most logical path to EHR integration or EHR usage, is using the tools that are kind of baked into your Epic or things like that. Now, whether or not those are like, kind of the default or things that you have to buy or things like that. But I it seems to me that seems to me that that's a likely vector of how we're going to see AI injected in a lot of this. But thoughts on
Can
that?
I ask a tangential question on what you're talking about right now?
Sure.
Do you know anything about like the liability of a external app that you engage with in a telehealth interaction? And I can follow up an email because we got a ton of AI stuff to cover. But it kind of touched on this, right? Like if it's not EHR integrated, you're using something outside of it, whether it's
Mhm.
through an API key or it's an app you got off the App Store or whatever, right? Where I'm headed with this is one of the vendors that we were using for a project we use has the app that they were using through the App Store, and they're going under, and that app will not have support. And maintenance past 2025, sometime 2025. I want to say June. And one of the health systems that we sent it to is basically like, is this a HIPAA concern? And I was like, I've never thought about this before. My immediate answer is no, right? Because the healthcare video platform is the HIPAA part. But the other part of it is like, if it's a non-maintained app, the liabilities there are non-zero.
I think it's a security concern at least.
Yeah, I would
mean-
I would look at that for more of a risk security.
Yeah.
HIPAA
So does
is
that
going to
play in here
come
though?
into that.
Like in the distinction you're talking about, does that play in here too? Like if it's EHR embedded, it's probably more secure.
Yeah, but
That's-
I think it would come back to like a BAA in place with the organization and whether that was still valid too, right? So spelling out protections, if they've gone under, there may not be people there to be liable for the app at that point or something.
Right.
Exactly. Or they're not doing their audits, or they're not, maintaining
Yeah.
the logs that they're supposed to maintain, right?
Yeah.
So, and a big piece of this too is like, is whatever app you're kind of talking about, is there any PHI or identifiable information, or what are you using it for, right? So, if it's non-patient information, that's a whole other element than if it is patient information, and then you really should be having some sort of BAA.
Right.
Mhm.
So part of the reason why I tossed it out is because I wanted to hear your questions. I think all of those seem useful to me when the people are like at the bottom of this, right? Like whatever at the bottom of our tip sheet. like questions you should be asking. You see what I'm saying? Because like it to like separate everything else, whether or not you're integrating this AI or you're going external, that's your first question. Whether or not you need a BAA because PHI, like there's that's part of the reason why I asked it now, and that because it felt relevant. It's also part of the reason why I haven't been sleeping well, because we deployed those to I'm not going to say on a recorded Zoom call number of group homes throughout the state of Maine.
Yeah, and then you don't know, like, are they going to sell those assets off to a Chinese company that's, like no longer no longer has to maintain the same level of security or do what they,
Right.
who has
Yeah.
insight into that
coming
data?
from a tech background into telehealth, I can tell you that tech companies go under all the time.
Right.
and that, as if you're Epic, right, you're going to want to pick a really big name kind of stalwart partner versus a little tiny startup to try and integrate with your giant platform. So
Yeah. I mean, that is,
So-
how do you reframe that as a question? Is it like partner, new collaborator versus collaborator by partnership or something like that? Because that's what you're saying,
Yeah.
right? It'd be true for Cerner. It'd be true for any EHR. If your EHR is offering it, it's a different level of vetting you need to do than if you just decided to go find this company.
Sure.
Yeah. There's a lot
Mhm.
of requirements, like to be in like the Epic marketplace, like to be added to their system. There's a lot of requirements about the companies and a lot of assessments that's done. So I think in the Epic perspective, if they've made it into the marketplace, Epic sort of vetted that company, and with the way the marketplace works is it sort of establishes the way to buy that service and embed it into your Epic implementation. So I
Yeah.
think and so I think it really depends on what you're looking at. And this kind of leads into some of the work around some of the diagnostics, because I think, right now there's sort of several different flavors of diagnostics coming out, and we've got all kinds of systems that are starting to analyze data, whether you're talking about diabetic retinopathy. I've got a solution, like Remedio has a solution determining if the image capture is good. It also has a solution that actually will, and theirs is not FDA approved yet, but there's another one that is, but it actually does the analysis for diabetic retinopathy. And so, and I think it depends on like what level, and I think that's where this gets tricky, is a lot of health systems like us at UVA, they don't want to buy anything that's not embedded. They want everything to be fully locked into Epic, so the providers don't have to go to too many platforms. And, that's really our goal now. Whereas it used to be, we had a lot of different things, but now everything is really tightly kind of integrated. And if we try to deploy anything that's not within that footprint, it raises a lot of question, because, then you have to have a provider that has to have a different app potentially or something else. And I think that's a challenge unto itself if you have too many different applications that are needed to like make things happen. So, having, fewer things that you have to tap, if it's embedded in Epic, it makes it easier. But I think, as you guys are discussing, it's the same thing we ran into when you talk about some of the peripherals that people are getting in the home devices. Some of the tech companies may or may not have been really medical, related as they got into the industry, and they're data companies that sort of found themselves handling, PHI in some regards. Some of them, even to the point of, there's still some like pulse ox and blood pressure cuffs that have somewhere in their user agreements that it's for entertainment purposes, even though they really do embed into health, apps now. And so I think it's very important looking at what those partners are. But I think when you start to look at it, there's different levels of things. Some are going to be pretty tightly, tied into your EMR, and then there's some platforms that are completely out there, on their own. And it's the wild west of telemedicine again, except for how AI gets integrated into these systems. And you see this land grab for people trying to look at patient management and, sort of your onboarding of patients. I apologize I didn't get some of that into the list, but I'll update the Bandcamp. But I've looked at a few different items, like the way that the diabetic retinopathy cameras go. There's a lot around like sugar, or glucose and stuff. We've seen Dexcom. There's also something called Signos that's more around like people tracking their own blood sugar, going for weight loss. That's sort of interesting. There's a lot of things out there that are sort of cobots now, meaning that they're designed for a physician potentially to be working, and then it's pushing information into the thread to provide, recommendations for kind of, paths to care. and best practices. So there's a few different ways that it gets embedded into and provides like diagnostic information for the folks. But it's pretty fascinating right now, just sort of the different levels of things that are out there and the ways that they're integrated. And I think right now we're still seeing a lot of things that are separate, because these companies are developing these technologies. But what I do see it is getting pretty tightly tied into the system. So you're not going to know where it's coming from, but it's all going to be embedded into your Epic workflow. So sorry, a little long-winded there, but
No, and that's great. And I think a lot of this, I mean, it's that tech adoption bell curve, right? So how risk averse is your organization, or are you as a provider, if you have the kind of freedom to do that? So in some ways, I think post-COVID, most organizations are more risk averse because they had to claw back after their kind of providers went out and did a bunch of telemedicine stuff. And, we had this giant proliferation of apps. So, everybody's a little bit more risk averse, but, if you are too much that way, you leave a lot of innovation on the table. So, I think there's going to be a lot of kind of like small scale pilot programs, but for most kind of embedded, kind of established systems, I agree. Working through the EHR, you're going to see a bunch of applications that were kind of built around some of these smaller, kind of more risk tolerant organizations that built these things, and then they get bought up by the EHRs and embedded, and then that's kind of how they're distributed to the healthcare system at large, right? All right. So Brian, that was good. Anything else on kind of in the diagnostic space? It sounds like you've done kind of a fair amount of digging, and then we'll have you kind of update the list.
Yeah, I'll put some of the stuff I've found. I mean, there's just so much information out there now,
Yeah.
and it really depends on what area you're trying to get into, whether it's like kind of patient management and that whole like kind of volley back and forth of information that happens. As I mentioned, the sort of the cobots, and then there's a lot of tools that are trying to do the diagnostic work. So I've been looking at Rapid, which is around stroke care. I've done a fair bit of looking at some of the stuff around medication management. I mean, because that's it's not exactly diagnostic, but it's interesting the way some of those systems sort of provide information and proactively work with the patient to get medication into them. But so I've kind of been looking at a lot of those services around like how AI is embedded and interacting with the patients and providing information. And, for me, I think it's going to be fascinating to have a group of people start to like talk through like where they already see AI embedded, because I think it's around, and I think I've said this several times, but it's already embedded in so many places and being used in kind of subtle ways that I just don't think a lot of people are aware of or thinking about currently. And, and that's what I found super fascinating about moving into this. But I'll update that list in the next day or so that you guys have some of the stuff that I've started to look at.
Yeah. Go ahead, Reed, and I might have a thought after
Brian,
that.
have you found anything on like the intersection between the two? Right, like, one of the things that I can't get out of my head is the fact that at least in the Northeast, the RPM model as it stands with EHR vendors being, or with RPM vendors being who they are in the workflows they have, might not be sustainable for small health systems up here, right? Like you lease these devices or you buy them, and 4 years later you're gonna buy them again. Meanwhile, like you don't have enough staff to be able to maintain all this data, so you offsource the data management, right? So somebody gets 3 reds in a row. A call center is letting one of your health providers know. Maybe you're paying enough for their interaction with the patient, in between. But that's where I'm headed with med management. If there's stuff on that and there's stuff on diagnostics, is there anything that's looking at RPM output?
I'm not that I've specifically noted yet, but now that you ask, I'm gonna do a little more like specific looking at it. I wouldn't be surprised if there's some companies that are at least claiming they're doing something. And I guess that's my other fear right now, is because some of these spaces are so kind of theoretical. I wonder if some folks are saying that they're doing things, but they may or may not really be pulling it off yet, but it's sort of where they're going. But I think around the RPM and sort of the data analysis, I'm going to do a little closer digging around that. I haven't looked specifically into that and sort of that intersection of the two. It seems like, a lot of folks are trying to set up sort of that information management service where they're sort of, I don't know. I'll send you guys a couple of examples of what I'm talking about. I found it to be pretty intriguing. There's a company called, I think it was Remedy, it's RIMIDI, and then there was one that was NICE. And between the two of those, it's kind of interesting, the models and the way that they're looking, because I think what they're doing is taking a bunch of different technologies and sort of trying to be that intersection for some folks. But anyway, I'll post some things for you guys so y'all can understand what I'm talking about.
Kind of like a co-pilot model, but for a provider, right? So like all the tools feeding into the. Okay.
Yeah, it's almost what it seems like. Where there's a lot of people, like, it seems like there's a lot of people just trying to figure out a business model in this space right now, and that's where I'd start. I wonder too, like, as you start to really dig in, I'm going to see like where the rubber hits the road, hits the road, like what it really looks like, I guess. So, because some of it just seems kind of theoretical right now, and I don't know, and that's where it could be almost like just a business model out there right now that somebody's put on a website and making it sound like something they're doing. But anyway, I think there's a lot of great information, and like I'll get some stuff updated on the list in the next couple of days. So
yeah, it's that search for the killer app, right? Like things are going to pop up, and then they're like they're bubbles, right? They're going to pop up and they're going to go away, and eventually a few use cases will really establish themselves and kind of become the thing that, like, oh, this is kind of what we can do with this.
Yeah. So I guess what I was going to mention earlier, and this is around sort of diagnostics and consent, the Rapid app is one of the apps that our neurologists use for doing some of their stroke consults. And, it's interesting because they use that for some of the telestroke consults. And so there's people that are showing up at the other hospitals, and I'm not aware of any consent around that and the fact that they use it. And that was one of the ones that we were having this discussion around consent, and whether or not, like, my coworkers like, well, I would want them to use it if they had it. And it's like, but it's interesting because these are folks that are coming into other emergency rooms. They're not necessarily part of our institution, but it's one of the tools that the neurologists use in the background when they're looking at the patients. And, it basically analyzes the images and helps do some of the determination for them and everything. And so, that's where it gets pretty interesting for me on consent, because, would the neurologist stop and work through some sort of consent when these folks are not necessarily at the main hospital and the way that the patients get brought in? But I'm going to have to do some research with what exactly is put in front of those patients, because we do this in consent as well. But if it's a tool that the doctor's using, background, I don't know. Like, and, probably it's got to be in something, but it's not a part of a study. I don't know where exactly that comes into play where they ask, but if then there were to be a lawsuit, it would be, that's where it would start to get kind of sticky, I guess. But so this is always a fascinating meeting for me. You guys are.
Yeah, no, we're gonna let Michael go. I want to get someone who's a little bit more. It feels to me like the consent discussion that we're having in telehealth now is not the consent discussion we were having 3 to 5 years ago. So it used to be like, oh, it's just part of your care. You don't necessarily need to consent, but some organizations do because they want to. But it seems like the trend is like, oh, we consent for everything now. But I'm wondering if we don't reach out to some of the other TRCs like CCHP, and then maybe maybe I know CTRC, like Sylvia has a lot of AM stuff she did with the AMA. I wonder if they have any insight for us. I might reach out to them if they've got anything really interesting to say. Maybe we'll bring them back to the group, maybe even next time, and see if they'd be willing to talk to us about what they're seeing in the space. But go ahead, Michael. You've been really, really patient.
Oh yeah, no worries. Just a quick comment on that. Back to the hazards of AI. Securing the AI technology is a challenge. I think it can be, from what I understand, fairly easy to poison the AI. So securing basically, it's like I guess sort of the very early example, like doing checking on the data people put into your fields on your website, right? To make sure that it's valid. Not exactly the same, but kind of similar. Just making sure the intake is as pure as possible to avoid, having the AI recommend things that just are could be harmful, I guess.
Mhm.
The other aspect that I didn't see in the document yet is bias. It's just difficult to avoid that in training AI or in the AI data sets that are used. And so how to make sure that the AI is appropriate for the patient that's being evaluated.
I was having a conversation with Garrett up here about AI use for Alaska Native populations. So the Alaska Native populations are so different than so many of the other populations, even other tribal Native organizations kind of across the country. So if you used an AI system that was trained on continental US systems and it was making recommendations based on those data sets, they could be very, very different than kind of what we see for our tribal health communities up here. So yeah, absolutely. Bias in the data set. I think this is one of the things that we'll have to kind of link out to some kind of best practices, but there's been a lot of conversation around here and it's just starting to heat up in terms of like, what people are talking about. But good point. We need to make sure that we're including that. Okay. Well, it sounds like for the sections that we have here, we all need to kind of go in and beef these up a little bit. Michael, was there a particular topic here that that you'd like to do kind of look into, or do you have time to look into one of these or more of these?
I can look into at least one, so I guess I'm pretty open. Happy to look into any of them. So
you seem to be interested in some of the hazards. Do you
Sure.
mind kind of
Yeah,
looking at
happy to.
yeah. I think that's a great place for us to look at. So yeah, all of that. We've not really fleshed that out yet. That's something that we've not gotten to. We're still trying to kind of nail down use case and kind of what some of the best practices within these categories are. Okay. Yeah, Reed.
In terms of like content design, and I feel like I've asked this question before, so apologies in advance, but like, is that something that TTAC's taken on? Or I mean, we've got a couple of different folks that do graphic design, sort of outside of their 8 to 5 in the MCD shop. Like like infographic or whatever, I could talk to my team over here if it made sense, but I didn't know if like that's something that you guys are taking on once we finally get to that stage. Or
It's not a skill set in our wheelhouse necessarily. If there was someone that could help out with layout and kind of prettifying the data once we kind of get it all together, that would be really, really helpful. If it was something kind of within the realm of reason that we needed to throw some money at, we have some kind of funds set aside for this sort of thing. We could probably do that to some sort of degree. Similar to also with the kind of the broadband as well, if we could kind of make it have a similar look and feel between the two different things that we're producing, I think that makes a lot of sense. So yes, there's interest. I'm not sure kind of logistically what kind of hurdles we would need to make sure that we're clearing to make that go. I could put some. I really like the format from that one document that you showed, kind of that quadrant format. I think that'd be a good thing for this, that we could look at each of these things and then maybe have a section on kind of hazards and resources.
Yeah. No, I was thinking similarly. It sounds like we have two fact sheets at this point, but so yeah, let's just follow up. I mean, I'll send you the pricing for that company we used, but I also think that our project coordinator, Michaela, her FTE could go towards emulating that, so to speak. And she does most of the like primary metric design at this point.
Yeah. We could also just get, I could pay for Chat GPT-4 and have it just build it for us. None of the text would make any sense.
We did a logo contest for our annual conference, and Andrew competed with it with his whatever subscription he has for AI. He was just like, I can do better than that. He lost, unfortunately. It was a fun little wrinkle to it. But yeah, all right. I'll follow up with at least the pricing for that company, and then if you guys are interested, I can give you a point of contact. Otherwise, I think we could definitely help out with that in the Netric MCD shop.
Just for giggles, well, here's my most recent foray into AI. So I'm trying to kind of look at like the levels that we interact with AI. So it's a little bit like what you were saying, Brian. Wait, is Brian still on? Oh, we may have lost Brian. But like some of the AI is embedded, you don't see it. Some of the AI is like a co-pilot that sits next to you. Some of the AI, like, is kind of off doing its own job and you don't pay any attention to it. You just look at the output that it generates. So this is my like AI inside logo, like, kind of taking, so I told it, take the Intel logo and then like put a light bulb or a brain inside. So this was what it kind of generated out of this. And then I had it had some text down here, but it was all just kind of garbled. So like it couldn't figure out what to do with the text, but it was trying to pull in the Intel text and it didn't know kind of what to do. But this is what I had Dolly do for me. But, okay, well, I think now that I'm showing my arts and crafts, we must be kind of reaching the end of the conversation that we had. I think kind of diving back into our different sections, fleshing them out a little bit more, and then coming back with a couple, like 3 or 4 kind of key points that we really want to hit when we talk next time would be a useful thing for us to do. I'm going to reach out to a couple of the TRCs that I know have a vested interest in kind of some of the consenting and kind of risk and liability pieces of this. Specifically, I think CCHP and CTRC probably have some good insights on this. The other one I think might would be Southwest. I know you guys have put out a lot of information, through your team, but I don't know if you've got anyone or if you have any particular insight in this, Michael, or have anybody that has some particular insights that they'd want to share.
I think Dr. Kopensky might. I mean, she gives talks on AI and has a lot of knowledge about it. So certainly she might.
So what I'll do, I think maybe is I'll post this to the Brain Trust, and I'll just put in the topic, and then maybe I'll add looking specifically at you, Dr. Kopensky, CTRC, and California. So okay, I'll go ahead and make sure we do that. But I think we've made some progress here. We'll take a closer look next time we meet up. And then Reed, if you can get back to me with some of the kind of layout and setup. If we need to do something that's a contract, that can be a little bit to get going here at ANTHC. So I'd like to kind of think about that sooner rather than later.
Yeah. No, I mean, I think I'd prefer to have our coordinator help me carve out her time for me. But I will do that stuff too, in case you guys prefer it. In that way, you also have backup pocket. You know who made it.
Yeah, I like that plan. If there's a free, cheap way to do it, that we're using in-house resources, I think that might be a better way. And then we have a little bit more kind of control over kind of the branding.
Yeah, for sure.
All right. Well, thanks everybody for your time. This was a good discussion. Appreciate it. And we'll talk to you guys in 2 weeks.
Sounds good. All good things, guys. Take it easy.
Thanks.
All right. Bye all.